All right, we are going to start with burns, if we start here. All right, so this is just a video if you guys want to take a look at it. I'm not going to play it right now on here for sake of time, but it's just kind of a good depiction of, of a burn and what happens with a burn center and the immediate post-operative, post-burn stages. You can see all the prioritization and what they're doing in this particular video. So the anatomy and physiology of burns, honestly, really, when you go to page 1809, it talks about, the physiology, the pathophysiology with burns. And honestly, the biggest thing to remember with burns is that it's the injury that occurs is really going to be what the physiology of it is. So it's the mechanism of the burn. It is the amount of surface that's burned, the amount of time that they've had exposure to the burn. Those are really the biggest components of the burn and what the most important areas are. The zone of burn injury we'll talk about more as well. The zone, includes obviously the coagulation zone, the stasis zone, and the hyperemia zone, which we'll get into more. But the other things that are important to remember is after a burn happens, there's a release of the catecholamines, which are part of your sympathetic nervous system. You will have like a fight or flight response when your catecholamines are released, and that's your epinephrine, norepinephrine. So you'll see an increase in blood pressure and heart rate with this, and you'll have vasoconstriction that's disrupted by blood flow. So the blood flow is not going to get to that particular area. You're going to have injury to the tissue. You're going to have increased capillary permeability. There's going to be edema anywhere, including, you can see it in the lungs. You'll see third spacing occurring. Edema is basically going to be anywhere. So a lot of times you'll see that the patients are going to look like they're in fluid overload, but they might be actually hypovolemic, especially in the emergent phase of a burn. So the decreased perfusion also will sometimes affect the GI system. So a patient with burn is also oftentimes going to have GI issues such as paralytic ileus, abdominal distension, Curling's ulcer, which is a stress ulcer. They like to ask about Curling's ulcer on NCLEX, which basically is just a stress ulcer that occurs, and what you're going to want to do with that is make sure your priority intervention is going to be making sure that they're on a proton pump inhibitor. Myoglobin and potassium are released secondary to the cell damage. You have the inflammatory response, which we just talked about. And then with the increased metabolic demands, you're going to have to really be looking at the caloric intake of the patient, making sure that you have early intervention with nutrition and making sure that you're able to do that. And also with oxygen demand, making sure you have a supply of oxygen. There's also the destruction of the red blood cells. So a lot of times you'll see the hematocrit is elevated, which is really a deceitful thing that we see with our bodies. And it's because of the plasma loss. Even though they have an elevated hematocrit, it's more a loss of blood volume that's causing the increase in hematocrit. They'll have a decrease in their platelets, and a lot of times they'll have a prolonged clotting or thrombin time. So we want to be really careful with that with these patients as well. Here's a good question. So when you're evaluating the lab values of a burn-injured patient, which of the following can be anticipated? With this, the answer is 1. We just talked about the hematocrit levels. So your hemoglobin levels are often going to be reduced in response to the hemolysis of the red blood cells, but your hematocrit levels are going to be elevated secondary to the hemoconcentration and fluid shifts from the intravascular compartment. Basically, your body has less fluid and it's going to be more concentrated. So you will have a low hemoglobin, but you'll have an elevated hematocrit. Severity of burns is going to depend on a lot of things. Obviously, with age, or young children and older adults are going to have more of an issue. The young children have less of a surface area. The depth, obviously the classification of the burn is going to be one of the big things. Your surface area, the big ones that I want you to look at are the rule of nines and the Palmer method. Inhalation injuries, if they have an inhalation injury secondary, it's also going to mean that, it's going to be a more serious situation. if they have other injuries that occur, and then past medical history, what comorbidities do they have that are going to influence their ability to recover or handle the burn. So prioritization of care. The patient is brought to the ED by paramedics who report that the patient has partial thickness burns on the chest and legs. The patient has also suffered smoke inhalation. What is the priority in the care of the patient who has been burned and suffered smoke inhalation? And your answer is always going to be airway management, D. The patient may need to be intubated. Even if they're stable initially, the airway may swell and needs to be a priority for the nurse to assess. So you really want to be careful when you have a patient who's had a burn injury. One of the first questions you want to find out is the mechanism. And if it is a fire and there's smoke involved, you want to make sure that you're monitoring their airway. And many times, even if the patient is not symptomatic of an inhalation injury, they may intubate them because they're going to protect the airway. Once it swells, you can't intubate them. You may need to do a trach. And it's going to get more complicated. So that is why you would potentially see a patient who does not have a visible or obvious airway compromise be intubated early on. Classification of burns. You're going to look at it's on Brenner's 13th edition. It's 62-1 is the chart, and it is on page 1808. What's important for you to look at here is when we look at the classifications of burns. So your first degree burn is something more of like a sunburn. It's that low intensity flash, superficial scalds. It's your person who has a sunburn who comes in. Clinical manifestations are in here, your skin involvement. It's the epidermis, possibly a portion of the dermis. It's reddened, and the big thing with this is it blanches with pressure. There's minimal or no edema and sometimes blisters, but not often. Basically, this person's going to have complete recovery within a few days. Sometimes we'll give them an oral pain medication, cool compresses. They may give them an ointment or lubricant for the area. This is your person who goes and sits out in the sun and falls asleep and their friends draw all over them. That's your first degree superficial. Your second degree partial thickness is the person who has like a scald, a flash flame, or some kind of contact burn. This is the epidermis and a portion of the dermis that is involved. The key with this one that's different is that it's blistered and it has a mottled red base. It does not blanch with pressure. A lot of times they'll be weeping at the surface with this too, and they will have edema. The recovery is a little bit longer with this. This patient is going to have, they're going to be sensitive when the air hits it. They are going to have 2 to 3 weeks for recovery, and there may be scarring and pigmentation issues afterwards. Sometimes they'll require grafting, not common, but could. With your third degree, which is your full thickness, this is someone who's had, prolonged exposure to hot liquids, electrical current, chemical contact. This is going to involve the epidermis, the dermis, and sometimes subcutaneous tissue is involved. And it could potentially involve connective tissue or muscle. With this, they're going to have dry. It's going to be dry. It's going to be a pale white with some red, brown, or leathery appearance to it, or charred. A lot of times when you see these questions on like an NCLEX exam or a test, what you want to look at is that they'll usually describe it as white or leathery. But the other thing is that it's dried. It's not like blistered and weeping like the second degree. With this, the eschar might slough a lot of times. They might have to do some grafting. There's going to be scarring, and a lot of times there might be loss of contour. So if there's a crater area, it might always be that way type of an injury. With your fourth degree, there's going to be prolonged exposure. A lot of times you see this with like the high voltage electrical type of burns. Or someone that comes to mind, we had a guy one time who had tried to sand his gas tank for his motorcycle in his bathroom with the door closed. He had circumferential burns on his arms. He had burns on his face, his chest, and he didn't have pain. And that's one of the biggest things with this that you'll see. A lot of times they're in shock and they're not reporting pain, and it doesn't have that in here. But you'll see it, I think it's in your reading, it talks about it. But a lot of times the big characteristic It involves deep tissue, muscle, and bone, and a lot of times they will not report pain. It doesn't mean it's not serious. It actually, when they say that they don't have pain and you have a really bad burn, that's really serious because it means that it involves pretty deep layers. You need to act fast. A lot of times with this, they'll need amputation. At this point, grafting is not going to help them. The depth and severity is too much. So the other thing to keep in mind is patients might have multiple types of burns. So they might have a combination of, second, third, and fourth degree burns. So that's the other thing that you will hear a lot of times when you're caring for a patient is that they have burns of multiple degrees. Prioritization of care. So the nurse is caring for a patient who has sustained a deep partial thickness burn injury. So our deep partial thickness burn injury. In prioritizing the nursing diagnosis for the plan of care, the nurse will give the highest priority to what nursing diagnosis, and it should be pain. So in that initial part of initial time after a burn, it is very, very important. Pain's really important, and it has to be treated as a priority in our burn patients. A patient experiencing a burn that is pale and waxy with large flat blisters asks the nurse about the severity of the burn and how long it will take to heal. With which of the following should the nurse respond to the patient? The answer to this is 1. If the wound is a deep partial thickness burn and it will take more than 3 weeks to heal. This is, in here that it's between your partial and your full thickness. It's going to take a few weeks for this to truly heal. The wound described is the deep partial thickness burn, and these wounds will take more than a few weeks. A superficial burn is usually red and moist, and it's going to appear glistening. It could have blister formation. The healing time for that type is usually a shorter period of time. With the full thickness burn, it's going to involve more layers, and it's going to take longer for the patient to recover. So the patient has a scald burn on the arm that is bright red, moist, and has several blisters. The nurse would classify this burn as which of the following? And the answer to this one is 1 and 2. So it's a superficial partial thickness burn that's bright red. And it has the glistening appearance, and it could have the blister formation. The thermal burns result from exposure to dry or moist heat. So that's where that one would fall. The ambulance reports that they are transporting a patient to the ED who has experienced a full thickness thermal burn from a grill. What manifestation should the nurse expect? And remember, when we said they have that full thickness burn, that's our 4th degree. So the answer to this one would be D. They have no pain, the waxy white skin, and no blanching with pressure. And those are the keys here. This is on page 1807 in Brunner. It talks about with full thickness burns, the nerves and vasculature in the dermis are destroyed, so there is no pain. The tissue is dry and waxy looking, or it may be charred. There is no blanching with pressure. Severe pain, blisters, and blanching occur with the partial thickness, deep 2nd degree burns. And pain is minimal with edema, blanching, and redness with our superficial 1st degree. The zones of the burn. We talked about this a little bit in the beginning. On page 1809 in Brunner's 13th edition, you have your zone of coagulation, which is your innermost area. Cell death occurs in this area. Then you have your zone of stasis, which is your middle area, and that's compromised blood supply, inflammation, and tissue injury. It may develop necrosis in 24 to 48 hours if blood supply is not returned. So it's important to get the blood supply going in these areas as soon as possible. Your zone of hyperemia is the outermost area, and there's the least amount of damage to this area. It may recover fully over time, so that's the area that has the least amount of damage. Percentage of burns. Rule of nines is the one that you're really going to have to know, and you'll know that by all the questions I put in here. The rule of nines is commonly used system of dividing anatomic regions into 9% areas and allows a quick estimate to begin treatment. The London Browder is very precise. I'm not going to test you on this. Just understand that it is basically more in depth than the rule of nines. I did put a picture in here just so you can understand it. And the reason that this isn't used as much in emergent phase is because you have to remember all of these. You'd have to find a chart. So the rule of nines is generally what you'll see used and what you'll need to remember for the testing. The Palmer method is used more for scattered burns, and it's where you use the hand, including the fingers, and it's the patient's hand and their fingers, to estimate the extent of burns. So your hand is considered 1% of your total body surface area, which is, again, includes your hand and your fingers. So if the person's hand is the 1%, you can determine if they have scatter burns, if something's like a splash burn or something of that nature, what the percentage for that patient is. Here's a picture for your rule of nines, and it's on page 1809 in Brunner's 13th edition. Question. So a patient arrives in the emergency department after being burned in a house fire. The patient's burns cover the face and the left forearm. What extent of burns does the patient most likely have? And it would be 9%, which is C, because 4.5 is for the face and 4.5 for the forearm. Next question. A patient is being admitted with second and third degree burns covering the face, the entire right extremity, and the right anterior trunk area. Using the rule of nines, what should the nurse calculate as the extent of the burns as being? So it's 22.5%, which is B. Using the rule of nines for these second and third degree burns, the face is 4.5% of the body surface area. The right arm is 9% of the body area, and the entire anterior trunk is 18%. Since the patient has burns on only the right side of the anterior trunk, that would basically be assessed as half of 18 or 9%. So if you add the 4.5, 9, and 9, you're going to get 22.5%. The client who's tripped while carrying an open kettle of hot water received scald burns to the entire chest, the entire anterior section of the right arm, and the right half of the abdomen, and the anterior portion of the left from the groin to the knee. At what percentage of total body surface area does the nurse calculate the injury using the rule of nines? And it would be A, 22 to 23%, and I'll let you calculate that just for time's sake here. Determining the depth. So an emergency department nurse learns from paramedics that they are transporting a patient who has suffered injury from a scald burn from a hot kettle. What variables will the nurse consider when determining the depth of the burn? And the answer is going to be A. On page 1810 in Brunner's 13th edition, it talks about the depth of the burn being determined by how the injury occurred, the causative agent, the temperature of the agent, the duration of the contact with the agent, and the thickness of the skin. So the answer to that one would have been A. Electrical burns is in chart 62-3 on page 1810 in Brunner's 13th edition. What it talks about is the flash injury, usually being the thermal burn with fewer complications, the conductive injury and the lightning injury. It discusses all of these in there. I'm not going to read this off the slide for you. But what's important is that you titrate the fluids to get 75 to 100 mLs of urine output an hour until the urine is no longer red. That's really important. And it talks about, the reason for the redness is the myoglobin in the urine. So we want to make sure that we're titrating when we flush out and get their kidneys functioning again as well. The other thing, fluids, you're going to often see 50 MEQs of sodium bicarb added to the fluids initially as well to buffer. Your CK levels are going to be looked at to determine the degree of muscle injury in the early phases. We just talked about your myoglobin and your serum and urine are indicators for the need for continued fluid resuscitation. So we want to get it down to reduce damage to the muscles and kidneys. CMP is going to give us an idea of our organ function with our BUN, creatinine, and our AST and ALT for our liver. Sodium bicarb is given to decrease the acidity of the urine. I was just saying we can add that to the fluids. And then a lot of times they'll do debriding, to get some of the tissue out of the area and get the vasculature, to determine the vasculature and see how damaged it is. So here's a question. The nurse sees a patient get struck by lightning during a thunderstorm on a golf course. What should be the first action by the nurse? And it's one, check breathing and circulation, because, of a lightning strike, it's very common that the person's going to have a cardiopulmonary arrest. The other actions are all appropriate, but they would be secondary to checking breathing and circulation. And here's the referral to a burn center. It's actually also on page 1809, chart 62-2. But this is another external link that'll talk about when we refer patients. So it's anytime they have a partial thickness burn that covers 10% of the total body surface area or greater, burns that involve the face, hands, feet, genitalia, perineum, or major joints. Any third-degree burns would be a good referral. Not a good referral, but would need a referral. Electrical burns that include lightning injuries, chemicals, inhalation injury, a burn injury in patients with pre-existing medical conditions, children with burn injuries, patients with burns or contaminant trauma, or never mind. If they have trauma alongside, I'm just not able to talk today. Patients who will require special social, emotional, or long-term rehabilitation too. So someone who's got extensive burns, and they're going to require more care than can be provided. Alterations. So with the cardiovascular system, the cardiac depression occurs, edema and hypovolemia. Due to vasoconstriction, compensatory mechanisms are going to come into play. Increased workload, heart rate's going to be up, blood pressure's going to be up. Your fluid and electrolytes, it talks about on page 1811. Burn shock is going to result from the combination of direct cutaneous injury, intravascular volume loss, and systemic inflammatory mediators affecting multiple physiologic systems. Your pulmonary effects are on page 1812. Inhalation injury, edema, vasoconstriction, carbon monoxide poisoning are all things that you can see occurring. Kidney function is going to be altered from decreased blood flow or blood volume, and the fluid volume will improve kidney function, so that's why we're giving fluids, and we're giving a lot of fluids. It's one of the things with burns is fluids. We're going to be giving tons of them, and we'll talk about that more. Immunologic on page 1813, the patient's at increased risk for sepsis with a burn. Thermoregulatory, skin loss, obviously with the inability to regulate their body temperature, they can end up with hypothermia, so we want to watch their temperature. And then with gastrointestinal, we talked in the beginning, they're going to have altered GI motility, they're at risk for paralytic ileus, Curling's ulcer, and translocation of bacteria. So we're just watching out for all of that. A lot of times we're going to have on a proton pump inhibitor and just watch them very, very closely. Inhalation injury. So the patient's admitted to the emergency department with first and second degree burns after being involved in a house fire. Which assessment findings would alert you to the presence of an inhalation injury? And it's A, singed nasal hair, B, generalized pallor, C, painful swallowing, and E, history of being involved in a large fire. So reliable clues to the occurrence of inhalation injury are the presence of facial burns, singed nasal hair, hoarseness of their voice, painful swallowing, darkened oral or nasal membranes, blackened sputum, history of being burned in an enclosed space, or altered mental status, and sometimes they'll have a cherry red skin color, which is them, their oxygenation issues usually. Phases of the burn, refer to page 1814, table 62-3. We have our emergent phase, and we're going to go through these more in depth, or resuscitative phase, which is the onset of the injury to completion of the fluid resuscitation. We have our acute or intermediate phase, which is the beginning of the diuresis to the wound closure. And we have our rehabilitation phase, which is from the wound closure to return to optimal physical and psychosocial adjustment. So here's a question. Patient in the emergent resuscitative phase of a burn injury has had blood work and arterial blood gases drawn. Upon analysis of the patient's laboratory studies, the nurse will expect the results to indicate what? The answer is hyperkalemia, hyponatremia, and elevated hematocrit, and metabolic acidosis, which are all common findings in that initial phase of a burn. So again, in our emergent resuscitative phase, All of these things are occurring. We want to prevent injury to the rescuer. It's stopping the injury, extinguishing the flames, cooling, ABCs, getting oxygen in an IV, keeping them NPO, removing any restrictive objects and covering up that wound, assessing everything, looking at all the body systems. It's when the patient's transferred to the emergency department, when the fluids are started, when a Foley's inserted. Anyone who has burns to 20 to 25% or more of their body should have an NG tube and be placed to suction, keep their stomach emptied. They're stabilized and the condition is continuously monitored. Anyone with an electrical burn should have an ECG. They're usually on continuous monitoring. Addressing pain. Pain is super, super, super important, and it's going to be IV pain medication because we have that patient NPO. Psychosocial considerations and emotional support should also be taken into account. So airway breathing, airway breathing, airway breathing. We want to just keep thinking, watch their airway. Also, if a patient has a fall and an electrical injury, we also will be watching out for cervical spine injuries. Another important thing is blood pressures. You can take a blood pressure on an affected burn area if you don't have any other options. You just have to make sure that when you're selecting a blood pressure cuff that it's appropriate in size and taking into account the edema that may be present. The other thing is the burgundy colored urine you'll often see, and that is going to be from the myoglobin, and it signifies that there's muscle damage, and that's why remember we talked about fluid to get rid of the redness in the myoglobin in the urine. Your emergent phase of fluid and electrolyte shift is happening. You're going to have the generalized dehydration, blood volume and hemoconcentration is reduced. Decreased urine output. Trauma a lot of times also will cause, the trauma from the burn is going to cause the potassium into the extracellular fluid, so you're going to have the hyperkalemia. Sodium's trapped in the edematous fluid, so a lot of times we'll also see hyponatremia, and that patient's going to have metabolic acidosis, which we just talked about. Prioritizing the care for this patient. The current phase of a patient's treatment for a burn injury prioritizes wound care, nutritional support, and prevention of complications such as infection. Based on these three priorities, the patient is in what phase? The answer would be C. These are our priorities during the acute phase of a burn. Labs. The client with 45% burns has a hematocrit of 52% 10 hours after the burn injury and 6 hours after fluid resuscitation was started. What is the nurse's best action? It's A, assess the client's blood pressure and urine output. The elevated hematocrit is expected because of the plasma loss. That's on page 811 in Brenner's 13th edition. I think we went, I gotta go back. I'm sorry, guys. Findings. Patient receiving treatment for severe burns over more than half of his body has an indwelling urinary catheter. When evaluating the patient's intake and output, which of the following should be taken into consideration? The answer to this is 1. The amount of urine is going to be reduced in the first 24 to 48 hours, and then it will increase. The patient's going to have an initial reduction in urinary output. The fluid is reduced in the initial phases as the body manages the insult caused by the injury, and fluids are drawn into the interstitial spaces. After the shock period passes, the patient will enter a period of diuresis, which usually starts between 24 and 36 hours after the burn. In caring for your patient with burns to the back, the nurse knows that the patient is moving out of the emergent phase of the burn injury when what happens? The answer is D. Remember, we just said in the emergent phase, the immediate life-threatening problems from the burn, hypovolemic shock and edema, are treated and resolved. Towards the end of the emergent phase, fluid loss and edema formation end. Interstitial fluid returns to the vascular space and diuresis will occur. The urinary output is most commonly used parameter to assess the adequacy of fluid resuscitation. The hemolysis of red blood cells and the thrombosis of the burn capillaries also reduce circulatory red blood cells. When the fluid balance has restored, dilution causes the hematocrit levels to drop. Initially, sodium is going to move to the interstitial spaces and remain there until the edema formation ceases. So the sodium levels increase at the end of the emergent phase as the sodium is going to move back to the vasculature. Initially, your potassium levels increase as it's released from the injured cells in hemolyzed red blood cells. So potassium levels decrease at the end of the emergent phase when the fluid levels normalize. Your acute or intermediate phase is your 48 to 72 hours after your injury. Really, again, the important stuff with this is continued assessment and maintaining your respiratory and circulatory support, preventing infection, making sure you're doing wound care. Pain is huge. Make sure you're maintaining, the patient so that their pain levels are low, and nutritional support are going to be priorities, which we just said a couple questions back. So during the care of a patient with a burn injury in the acute phase, which new interventions should the nurse expect to do after the patient progressed from the emergent phase? And it's B, monitor for signs of complications. Monitoring for the complications, which would be your wound infections, your pneumonia, your contractures, is needed in the acute phase. Fluid replacement starts in the emergent phase. Assessing and managing pain and anxiety occurs in the emergent phase and the acute phases. And discussing possible reconstructive surgeries is done in the rehabilitation phase. So fluid and electrolyte shift during the acute phase. We talked about here the sodium's lost with the diuresis, so you're going to have the hyponatremia. Potassium shifts from the extracellular fluid into the cells, so you could potentially have a hypokalemia. You're still going to end up with a metabolic acidosis at this point. Increased urinary output. Remember, we said they're diuresing here. So that's all important. And then fluid's going to enter the vascular space from the interstitial space as well. Airway protection. A nurse on a burn unit is caring for a patient in the acute phase of burn injury. While performing an assessment during this phase of the burn, the nurse recognizes that airway obstruction related to upper airway edema may occur up to how long after the burn injury? And the answer is A. Up to 2 days following the burn, you may have a patient begin to have complications, which is why I said in the beginning, many times you will see that the airway is protected and they will leave a patient intubated for several days to get them past this point. Prioritizing care. So the patient was burned in a workplace accident and has completed the acute phase of treatment, and the plan of care has been altered to prioritize rehabilitation. What nursing action should be prioritized during this phase of treatment? The answer is B, providing education to the patient and the family. They're moving towards the rehabilitation phase, which is begun as early as possible in the emergent phase and extends for a long period after the injury. Focus in this point is really supporting the patient, the self-image, functional abilities. This is when we're going to talk about reconstruction and reconstructive surgery. And it's also when we're going to be working on vocational counseling, talking about, how it's going to affect their life, both from a work perspective and a life perspective. And a lot of times support groups, not only for the family, but also, not only for the patient, but also for the family. Fluid resuscitation is another big thing. These are some of the different formulas. We're going to focus on the Parkland formula for here. And when I give you formulas, that's really what I would test you on. I wouldn't test you on any of the others. So here comes the Parkland formula. The nurse is caring for a patient with, I forgot what page this is on, but we'll talk about it, with second and third degree burns to 50% of their body. The nurse prepares fluid resuscitation based on the knowledge of the Parkland-Baxter formula that includes which recommendation? The answer to this one is B. 1/2 of the total 24-hour fluid requirement should be administered in the first 8 hours. So fluid resuscitation with the Parkland formula recommends that 1/2 of the total fluid requirement should be administered in the first 8 hours, a quarter of the fluids over the next 8 hours, and then the other quarter in the 8 hours following that. So in 8 hours, they'll get half, and in the next 16, they'll get half divided in 2. Here's that formula. So again, this is the calculation. It's 4 mLs times the body surface area, the percentage of the body surface area burned, times their weight in kilograms. The first half is given over the first 8 hours and the other half over the following 16. Using the Parkland formula, calculate the fluid volume for a 154-pound woman who has sustained a 36% mixed deep partial, and full thickness burn. So the amount of fluid would be 154 divided by 2, which is going to give you the kilograms, times 35, which is the percent. It should have been 36, but I think I did it wrong. So it'd be 35% times 4. And now I'm going to be doing this with you since I did it wrong in the first place. So it'll be 154 divided by 2.2, which is going to give us 70. And then I have on here times the 36 times 4, which is going to give us 10,080. And if we divide that by 2, I actually did the math right. I must have just put my numbers wrong. It would give us 5,040 mLs in the first 8 hours, or 630 mLs per hour for the first 8 hours. So yes, that's a lot of fluids, but that's what you're going to want to give. The next 16 hours, you're going to give an additional 5,040 mLs. So that would be the equivalent of 315 mLs an hour. So for our burn and wound care, refer to page 1822 in Brunner's 13th edition, table 62-4. It talks about the use of topical agents. So it talks about the wound cleaning, so our hydrotherapy and how we're going to clean them. It also talks about the wound debridement, whether it's natural, mechanical, or surgical. So take a look at those. Burn client has asked the nurse not to remove the loosened bits of skin and tissue during the dressing change, saying, "The more skin you take off, the longer it will take me to heal." What is the nurse's best response? And the answer is D. The tissue is no longer living, and as long as it's present, the real healing can't start. So when there's dead tissue, it often is removed, and that's part of the purpose of the debriding. A lot of times they'll go in and take that off to try to promote healing. A patient has experienced an electrical burn and has developed thick eschar over the burned site. Which of the following topical antibacterial agents will the nurse expect the physician to order for the wound? And the answer is B, and this is on page 1822. It actually diffuses through the eschar in the avascular tissue, and it's the only one that does, which is why the drug is the drug of choice for a site with the eschar. So if it's a 4th degree burn, this is what you're often going to see, or the some of the 3rd degree, you'll see that particular medication ordered. Grafting. Patient's burns have required a homograph. During the nurse's most recent assessment, the nurse observes that the graft is newly covered with purulent exudate. What is the nurse's most appropriate response? And the answer is B. Inform the primary care provider promptly because the graft may need to be removed. The purulent exudate, you don't want to see. It's a sign of infection, so it would be something that you would definitely need to report right away. So we have our autografts, which is from that particular person. They would take a piece of the tissue from one area and put it to the other area. Sorry, I'm just looking at my notes here and make sure I have everything. So a lot of times the graft loss happens from infection or trauma during dressing changes. Care of the graft site, that's really important, is protecting the site. Sometimes they'll use splints to immobilize newly grafted sites. The first dressing change usually isn't for 2 to 5 days after surgery and earlier if infection or bleeding is suspected. Positioning and turning is often avoided to that particular area to avoid disruption. If it's an extremity that's grafted, they'll often tell you to elevate it. The patient can exercise the limb 5 to 7 days after surgery, so they're not going to want to moving it too much until after that. The homograft and the xenograft, basically the homograft is skin used from deceased or living human other than the patient, and the xenograft is usually from animals. It's most often pigs. Eventually, the big thing with the xenograft is eventually your body's going to reject it. They may be used until an autograft is possible, if it's possible, and in place for varying lengths of time. There's skin banks that I didn't even know that, but there's skin banks where you can actually get skin from. Homograft is the best infection control over the xenograft, and revascularization occurs within 48 hours. The graft may be left for up to several weeks. Pain management is super important with these patients, and it's almost always going to be, not always, I mean, you always want to do IV pain medication. When we're doing any type of dressing change, too, always want to be thinking about that, too. Pre-medicate before any type of wound cleaning or any type of dressing change. A lot of times they'll have, a lot of different types of pain, whether it's just always there, if it's breakthrough, or if it's procedural when we're doing a dressing change. So again, IV pain medication is important, whether it's morphine or fentanyl or any other type of drug. A lot of times it's trying to keep them calm. The anxiety can make the pain worse. There's a lot of issues with sleep deprivation from the pain, so we really want to try to control it and try non-pharmacologic stuff like, whether it's meditation, music, a calm environment, explaining things to the patient ahead of time. Whatever you can do to try to minimize the anxiety is also going to help with the pain. So a patient who is in an acute phase of recovery from a burn injury has yet to experience adequate pain control. What pain management strategy is most likely to meet the patient's need? And it's A. PCA is really a good thing to let the patient be able to manage their pain themselves as well and not be waiting for pain medication. Nutritional support is another really important thing. Again, we talked about the metabolic needs of patients who have burn injuries. Nutritional support is used to promote balance. And again, a big thing, with this is going to be protein with these patients. Enteral roots preferred, but if we can't, then we're going to often have them on TPN. So the nurse is evaluating the adequacy of burn-injured patients' nutritional intake. Which of the following lab values is the best indicator of the need to adjust the nutritional program? And it's 1, glycosuria. Glucose in the urine is seen after major burn injuries, and it signals the need to reevaluate the nutritional plan. Creatine phosphokinase is used to identify the pressure of muscle injuries. The BUN is going to evaluate the kidney function. The hemoglobin is going to fluctuate during the different stages. We've talked about that. And the sodium level is not indicative of their nutritional status. The nurse is caring for a patient with partial and full thickness burns to 65% of their body. When planning nutritional interventions for this patient, what dietary choices should the nurse implement? The answer to this one is D. We just said that they need the high protein, but they're also going to need high calorie. The hypermetabolic state that occurs proportional to the size of the burn area. So massive catabolism can occur and is characterized by protein breakdown and increased glucogenesis. So that's what I was saying, you're going to have that glucose levels, which may mean that they need more caloric intake or more protein. The caloric needs are often in the 5,000 kilocalorie range. So you really want to make sure that you're giving them enough calories. Failure to supply adequate amounts and an adequate amount of protein can lead to malnutrition and also delayed wound healing. Complications, and I'm not going to get into these in great depth because we've already covered them, but ARDS is one of the big ones, respiratory failure, heart failure, pulmonary edema, and sepsis. And you guys at this point know what you're looking for those. Home care, obviously the mental health, supporting them, support groups, talking to them, making sure that they have adequate resources. Skin and wound care, where they have like home nursing, exercise and activities, talking to them about the need for passive and active range of motion, nutrition and emphasizing the need for high protein diets, pain management at home, thermoregulation and clothing, explaining them the need for that and covering the areas of the burns. And obviously sexual issues are going to arise, especially when you have burns to certain areas, including the perineum. So that's another big thing. And then pain and all that stuff, relationship issues, there's a lot of different areas that you can refer them to. Complications during the rehabilitation phase, take a look at table 62-5 on page 1829, but these are all things that you want to make sure that you're looking at. Range of motion. So when teaching a patient about the use of range of motion, what explanation should the nurse give the patient? Select all that apply. The answer to this is B and C. Active and passive range of motion maintains the full body function of body parts and reassures the patient that movement's even possible. These are explanations that should be used. Contractures are prevented with range of motion as well as splints. Movement facilitates the mobilization of fluid and the interstitial fluid back to the vascular bed. Although it's good to collaborate with physical therapy to perform range of motion during dressing changes. I don't know, I lost where I was going. Because the patient's already taken analgesics, range of motion can and should be done throughout the day. You really, again, so B and C. So exercises are not the only way to prevent contractures. There's other things that can prevent them, such as, like I said, the splints. Movement facilitates mobilization of the fluid, back into the interstitial space. And then the last one was active and passive can only be done, and it's not only when dressing changes, it should be done periodically throughout the day. I hope this helps, and reach out with any questions.